Good morning, everybody. The little note on my computer says that the recording has started. So welcome to this meeting of Northumberland Primary Care Commissioning Committee. We have a few apologies for absence. So Barbara, if you would be kind enough to run through the list, thanks.
Yes, we have we've got apologies from John Conley, and Richard is attending in his place. Adam Foster, Dave Thompson and Paul Turner.
Thanks very much, Barbara. Item 1.3, any declarations of conflicts of interest? Anybody got a hand up? Nothing at the moment. If anything comes up as we go through the agenda, just put a hand up or call out. Thank you. And item 1.4, where I think, strictly speaking, we're not quorate yet because we need either John or Siobhan to be quorate. Siobhan is joining us, but she is at another ICB or ICS, I'm not sure which meeting at the moment. So she'll be a few minutes late. So we will be quorate once Siobhan arrives, but we don't have any decisions to make in the meantime. So we'll proceed with the routine business in the meantime. So that then takes us on, welcome Chris, takes us on. We were warned you might be a moment or two late, Chris, and we've literally just started.
Thank you, apologies.
No problem at all. That takes us on to item 2.1, which is the minutes of the previous meeting. I won't go through them page by page to save a little time, but first of all, in terms of accuracy, I know, I think, Karen, you had something you wanted to raise on that.
Yes, it was a query on page 2 under agenda item 3.1, the third paragraph. The way it reads, it looks as though we're reducing the primary care budget. I just think it just needs rewording. Yeah, thanks, Karen. That's been run past John because he couldn't be here. And I think you're also aware of that, aren't you, Richard? And yeah. John is happy that should be amended. And I think I haven't immediately got it to hand, though I could find it. Do you have the form of words that you propose, Karen, or shall we amend that afterwards? I don't know where I've put them. I emailed them to you. I'll find them. Oh, do you have them to hand?
I do have them. Do you
Brilliant,
want me
thanks,
to
Barbara.
read them out, or
yes,
just
read them out so the committee can comment.
Yeah, the new wording is JC confirmed primary care funding is not being taken away from primary care. The amount of funding being put into primary care is being increased by the CCG to cover the underlying gap. In summary, there is a 3.5 million shortfall in the allocated budget of what the CCG actually requires. And then it continues, JG thanked JC for confirming the position of funding. And reiterated that GPs were aware that the CCG has been subsidising the gap from CCG general funding in primary care with no loss to primary care, adding that the CCG has supported general practice very well. And that's the paragraph.
Thanks very much, Barbara. Are members happy that that more clearly reflects what John was saying? Yeah, and obviously more to the point, John is happy with that as well. So we agree that that should be amended. Thanks, Karen. Any other matters of accuracy? No, everybody happy? Any matters arising which are not covered elsewhere on the agenda? No, everybody happy that those are a correct record. Thank you very much indeed. That takes us on to item 2.2, which is the public action log. And there are a couple of ambers there, which I think, in fact, may already have been dealt with. We've got one for Jamie Mitchell marked in progress. Is there anything to add to that? No, Jamie, you're happy with that? And no questions from anybody on that, no. And the recovery of practices, that's in progress. And Pamela will give us a brief verbal summary of how we're getting on with that on the agenda. Otherwise, everybody happy that though the action log is completed. Thank you very much. That then takes us on to the operational section at number 3. So 3.1, we've got the finance update from Richard.
Thanks, Chair. Thanks, Janice. Yeah, so in the papers you have the month 11 finance update report for primary care. Areas I'd like to highlight in that report are, the CCG continues to report a position that's consistent with the previous month's positions that have been reported to this committee. And that's roughly in line with the planned allocation the CCG received this year. So that's a forecast underspend of 0.3 million reported in month 11 versus that planned allocation. The report also mentions within that there's a proportion of that funding that's retrospective allocations, and that's mainly due to the additional rules and reimbursement funding and the winter access funding. And there's a proportion of those allocations that's held centrally by NHS England. And I can confirm that we've now had those allocations for the final accounts, which we are currently doing this week. And that removes any risk around anticipated incomes on those. And I know that's something that's been raised at sort of finance committee as well around a potential risk for the CCG. So we've got all those things in from NHS England now. For the other CCG commissioned primary care services, again, those are in line with what's been previously reported for things like GPIT, the primary care commission services out of hours, and the GP forward view allocations. Like I just said, we are in the middle of annual accounts at the moment, and we're nearly closed down, and I can pretty much say that these positions are in line with what the final positions will be for these areas. I mentioned there's the sort of versus plan, and that's different to the underlying position, which you've just touched on there in the minutes from the previous meeting. And at the bottom of page 6 of the report, it talks about that underlying risk. And through the system planning process that we've had at the minute under these temporary financial arrangements, we have been able to increase the funding in primary care to cover that recurrent gap, as we've just changed the minutes for what was said in the previous meeting. I was just going to touch on there's a number of reasons why there's that gap, but essentially it's to do with the how the national allocation formula has worked out, and how that's aligned with expenditure growth. So nationally that will balance, but when they dish it all out through the national allocation formula, there is winners and losers at CCG level, and in Northumberland sees a less allocation versus the expenditure requirements there. So that being said, I don't think this now represents a risk to the CCG as an entity, because of the way the system funding arrangements have now been rolled forward into next year as well. So this will cover the final 3 months period of the CCG before it becomes an ICB. So I don't think it's no longer a risk for the CCG primary care as an entity, but I would say this is on the radar of the incumbent ICB, and it's definitely on John's radar. And this will be escalated and investigated, because it's not just Northumberland in the ICB that it relates to. There is a few other CCGs have had a similar issue, and we'll escalate this as an ICB through the national allocation groups to see if there's any potential to influence future allocations and how the formula works. And John is keen to do that in the future. So that's all I was going to say. If there's any questions.
Thanks very much, Richard, and welcome, Siobhan. You'll have realised where we've just been through the finance update, and of course you're already familiar with that, so you would know what we're talking about. I've got Jane with her hand up, and then Pamela. So Jane, thanks.
Thank you, Richard. It was just to ask whether there was any information on whether this, underlying deficit, which has been there for 20 odd years, has increased due to the changes in the national allocation formula, which were reputed to be disadvantaging those, those in the north. So has this been an increasing position as regards Northumberland, or is it sort of a steady position, similar to the ones you've managed for the last 20 years?
For the delegated allocation in particular, it's an increasing risk, and that's because the expenditure requirements for the expansion of additional roles in PCNs is the expenditure isn't in line with the allocation formula. So we are funded in a deficit to those additional requirements every time they ask you to do something new. If that existing formula is still in place, the gap will continue to grow. I was just going to add that when we get to an ICB, we'll no longer have a place allocation or a CCG allocation. So it'll be the ICB will get one allocation for delegated for the whole patch. So
I was going to ask that later, but you said you referred to the funding, the ICB allocation rules. Is that published now, or is that still?
So yeah, we've got a delegated budget for the whole patch for next year. Yeah, but because the CCG is still working for the first 3 months of the year, that allocation's been split on sort of the existing split across the CCGs for next year. But then in the future there'll be potentially a different proportion split,
Right, so
and that might be based on spend rather than historic allocations. But that is for the ICB to decide going forward.
Yes. So will that be? So you're saying status quo till March 23?
Yeah.
Thank you.
Yeah.
Thank you very much. Thank you.
Thanks very much. I think we turned that corner of an increasing deficit. Was it between 3 and 4 years ago, wasn't it, Richard, when our allocation stopped keeping pace?
It was 2019-20, I think. Yeah.
Yeah. Thanks. Pamela?
Thank you, Janet. I just wanted to ask Richard, just based on the point of the clarity in the minutes last month as well, there's a number of elements of the PCN budget and other budgets to general practice that are affected in different ways with this allocation issue. Are we as a CCG within the first 3 months of this year able to guarantee the practices and networks will receive the contracted levels of funding regardless of this allocation deficit to Northumberland, just so we can give that assurance that they will receive what the national contract states? And then is that likely to continue for the rest of the year? So do we have a guarantee for the providers they will receive what they've been informed in contracts rather than what we've received?
So that assumption is in the current plan for places, CCGs and ICB next year. So it's the gap is funded in the system plans as it stands. Now I have to say as it stands because the final plan hasn't been submitted yet, but the draft plan has been, and it's in the draft plan. So yeah, I mean the final plan goes off the end of this month, I think. But I don't expect there to be any changes. But obviously I can't say until it's actually submitted.
Thanks, Richard. Did you want to come in on that one as well, Siobhan?
Please. One of the things that I just wanted to highlight was that despite the gap in those budgets, the CCG chose to fund it from CCG funding allocations. And I think that's really important because it shows how important primary care is as part of the whole system. So it will be interesting in terms of the future about what we do with this.
Yes, thanks, Siobhan. And I think it is good to know that the new finance director further up the line is somebody with considerable experience in primary care. So he will carry that as well as all his other knowledge and experience further up the line. So I think that's good to know. Everybody happy in that case that we have noted and commented on the finance update? Thank you. That takes us on to 3.2, which is the quality assurance report. And Claire, Robin, I don't know if you're doing a double act on this one.
Yes, Jan, thank you. Yeah, we are going to do a double act on this one. So just to introduce Claire Coyne, so she's Deputy Director of Quality and Patient Safety and is a patient safety specialist. So we are going to do a double act. Claire very kindly stepped into the role of chair of the local quality assurance group which is well established. So she's been able to bring a fresh pair of eyes into our processes and into that meeting as well. So thank you to Claire, and thank you too for her work in helping pull together the PCCC report that you've read and received. So I'll just let Claire introduce this part of the agenda and this paper. Thanks, Claire.
Thanks, Robin, and thanks everyone. Nice to be here. So I'll just briefly give a very brief, you've seen the paper, so a very brief overview of this sort of QA report. And this updates on data of Q2 and Q3, so Q2, Q3 of 2021-22. So the data is always fairly delayed with some of these clinical indicators. So that's the position we're reporting on. And apart from monitoring the performance, we look at other levels of soft intelligence, try and triangulate some of the data, and that's the work of the local quality group that Robin referred to, and using a quality assurance framework to do that. But before I start, it just goes without saying that the significant pressure primary care been under through all of this period and continue to be under. So that's the backdrop where we're looking at these figures and these indicators for, with obviously the pressure from the recovery programs, the vaccination programs, and the level of staff sickness during these periods of time. But this report covers a number of aspects, the clinical indicators. It looks at some of the performance indicators, such as the medicines management, cervical screening, SMI and LD health checks, and anything in relating to safeguarding, and just a brief update about the sustainability visits from the primary care team and the practices. So in brief, we've got Q2 data for cervical screening, and there has been an a slight increase in uptake between Q1 and Q2. And currently, we don't have the Q3 data ready for this report, but there has been a slight uptake there. In terms of medicines management, there's been no risks identified through the medicines management group, but with a fairly strong performance in terms of the practice indicators for that. The areas where, whilst there has been a very slight improvement between Q2 and 3 and for SMI health checks and the LD health checks, it still remains very low. So that is an area of sort of concern, and it's been flagged up through CMB as well, and it's an area of focus for the CCG about how we manage to improve that, and hopefully there'll be some improvement in Q4, which will be present next time. And CCG leads and the community LD team was trying to support practices to improve that for the last quarter of this year. In terms of the clinical indicators, we're focused on a number of areas, and Robin's going to come to that in a little while, but there's been no serious incidents that have been identified, and from a safeguarding perspective, the name nurse for the GP practices has been supporting the practices with lunchtime training sessions and supporting their family meetings, just to try and provide that extra support during this difficult time, and increase in safeguarding reports. And again, from a sustainability visits point of view, they've continued the rest of this year remotely, and the focus continues to remain around the workload, around the issues around the pandemic, and any data requirements and some of the estates issues that some of the practices are experiencing, and the formation of PCNs, and that's generally been the agenda for all of this past year. There's just a brief update in terms of CQC there, and we've asked the CQC to advise us of any ongoing visits because they're going to start to restart their normal programme of inspections and visits. And we do have a CQC rep who's part of our group, so that's a really positive move. So the CQC rep sits on our local quality assurance group, which is really helpful actually. So I'm just going to hand over to Robin just to go over a little bit about the clinical indicators, and then we should be done.
Yeah, so your committee will recall we wrote to 5 practices whose data seem to be outlying. We chose level 2 indicators, which means they're significantly outlying from their peers. We wrote to those practices. We asked them to produce a narrative really about were they aware of these areas where they're outlying and what their plans were. And then with the hope that over the following quarters, performance would improve. So of the 5 practices that we wrote to, all of whom constructively wrote back to us, 4 of them have continued an improving trend. One of those 5 still, however, remains an outlier. And in addition to that, a new practice has come onto our radar, showing that they are a significant outlier as well. We'll give a bit more detail in the private part of the meeting, but those 2 of those practices will be written to. I've already contacted them just to give them the heads up, because it's important from a transparency point of view. And the other 3 practices who have improved, we will be writing to them as well to affirm them, to say well done and keep going. Yeah, so that's the position we're at the moment from the quality indicators point of view.
Thanks very much, Robin. Any questions or comments from members? No. Can I just make one comment, possibly to question Robin or Claire? On the serious mental illness health checks, I am concerned that the last report said, and this report says, that we expect to achieve our 60% target by the end of the year. But we've only made about 1% improvement per quarter. So frankly, unless we have a really dramatic improvement plan, you know, I can't sit, admittedly from the outside, I don't know what's going on inside, but from the outside, I just can't see how we can realistically expect to achieve that target. So I'm hoping you can tell me there is a very clever plan and that it's somehow backloaded and will work.
Well, linked to the private part of the agenda, what one component which would give us a very quick win, if you can frame it that way, is that actually we've got 4 practices who don't actually produce the data that we require for the SMI health checks. So that will be discussed in the private part of the agenda. So if we can get the data from those 4 practices, that will make a significant dent in the figures. But you're dead right in terms of the aspiration. I mean, we have to aim high here, and as I said, we have actually, this is cited at CMB, that is a really important area because it also fits into the inequalities issue. So we know the issues about SMI and LD health checks, and in terms of the disparity in terms of outcomes, and it is a high priority area, which is why it remains focused. On the one hand, we've got to be realistic about where general practice is at, but I'm also optimistic that practices have the ability to do it, but it's multifactorial. So if the tail of COVID does significantly lessen, staffing stabilizes, then I'm confident the practices very quickly will actually, because they know it's a priority area and they'll achieve it. But you're right to draw the point. If COVID continues and staffing pressures continue, we're not going to hit that target. So I guess we've got to aim high, haven't we?
I think there's a difference between aiming high and expecting. I think, you know, if we say we expect, then you are literally raising our expectations. Could I also suggest, in any situation, but particularly with an important target like this, that it might be useful to have an accurate figure? And clearly at the moment we've got a percentage figure which is not right because of the 4 practices that haven't contributed. It would be helpful, I think, if one of our analysts or statisticians, and I'm sure for them it's, you know, it's a work of a second or 2 in their just mental arithmetic, what percentage we're achieving if we knock out those 4 practices, because at the moment presumably we're working on the basis they've done none at all, and we're hoping that that will not be true. So I think it would also be helpful. I think we need to look at whether this is an aim or an expectation. If it's an aim, is it realistic, and how we're going to achieve it, and an accurate figure taking into account we just don't know about 4 practices, I think would be helpful. Thanks. Karen, did you want to come in as well?
No, I was going to raise exactly that same point you've just raised there, Janet.
Right. Thanks, Karen. And one similar sort of question. We don't actually say on the learning disability checks whether we expect to achieve the target. Do we have a realistic expectation that we will do well on that?
I can pick that up, Robin, if you like. I think
I think last year, comparing it to the data for last year, a lot of it was backloaded into Q4, and that's not being realistic in terms of the impact of Omicron and lots of the staffing gaps we've had in primary care. So whilst there's been some support from the community LD team into practices to try and help that, I think very much like you said, there's very much an aim to get there. I don't think we will get to that percentage point this year for that, but the work continues, and the clinical lead, so Kathy Peterson's really trying to put some support out to all of the practices around this and try and keep that focus, and some helpful guidance and some helpful tools she's been sending out to practice to try and support that. But I think the biggest impact has been the staffing and staff to support a person with learning disabilities into practice or whatever, because it just takes a bit longer time if it's a face-to-face appointment for that annual health check. So I don't know if that answers your point necessarily, Janet, but I think that's the position we're in for this. That's what we'll find this quarter, Q4 data coming forward.
Okay, thanks. And I think maybe Robin mentioned in the past, these are appointments that have to be dealt with by doctors in a particular way. So there is quite a big staffing issue. Okay, anything else from anybody? No, in that case, we'll note that report. Thank you. And that takes us on to item 3.3, which is revisiting the progress on recovery of practices post-COVID. Pamela, there hasn't been time because of COVID and other illness delays, unfortunately, to prepare a full presentation on this. But I think, Pamela, you're going to give us a brief verbal update to keep us going in the meantime, just so we've got some idea of how we're heading. Thanks.
Yes, thanks, Janet. We do hope to bring a report formally to the committee at a later date, as you say, just due to sickness across the teams. It hasn't been possible, but I thought it might be good to take the opportunity to let the committee know that we've obviously invested a lot of the winter access fund into practices to maintain some staffing levels and support into practices, which has been quite significant across each of our practices. And I think it lines up very much with what Claire and Robin have summarised there about the continued pressures, vaccination programmes. But given that we're now into April, we will be able to get some data on the quality and outcomes framework. And we can compare that to last year and some data we gathered from practices, so we'll get some comparisons. So yeah, that is the position. We have put business continuity at the Primary Care Commission service as well to support networks and practices together. But to present a position at this point, it is too early to say with the data and some of the gaps in sickness, but we will come back.
Thanks very much, Pamela. Are there any interim questions from anybody? No, thanks very much. We look forward to that when there's been time to do a fuller report. Thank you. That then takes us on to section 4, the strategic section, and we've got a presentation from Jamie on estates and premises with a progress update, which will be interesting. So over to you, Jamie.
Okay, thank you. I'll see if I can share my screen. Just let me know if you can.
I can see it. I hope everybody shout out if nobody else can. No, everybody's looking happy, thanks.
Right, brilliant. Okay, so yeah, so when we sort of started and we developed the estate strategy, you know, we did pull together initial kind of criteria of where we thought our most need and priority sort of areas were. It was based on a limited set of data, you know, which we've since sort of grown and progressed from then. But essentially, it was a core set of sort of principles and a basic sort of priority list to sort of start us off with. And we had an overall ambition. Obviously, we wanted to make the estate sort of, you know, fit for purpose. We wanted to deliver sort of change, make it more efficient, and be able to sort of sustain the sort of progression of the primary care networks and improve sort of patient outcomes, etc. So that was the overall sort of ambition, and we sort of started to work on that. Sort of initially, we sort of tried to focus on the quick wins, really, sort of, you know, where we could repurpose the vacant space, because we did have some vacant space across the patch, and there was some sort of real sort of key needs. So C houses, Broomhill in particular, we had vacant areas. Broomhill was a dental area that we were able to sort of open up and provide to the practice to give them some more sort of clinical space. C houses was more of a sort of moving things around to make the patient flow a little bit better, and that was done, you know, primarily as we went into sort of COVID to allow for sort of social distancing. Gables, there was that sort of consolidation that we did because we knew that that branch surgery site that they had in Camas was in very, very poor condition, not really fit for purpose. So that was about getting them out of that sort of awful sort of premises, extending their existing site at Gables to give them some more clinical space. And we were lucky enough to secure funding with NHS Property Services to fund that. So that was a really sort of good bit of work, and that's just about to sort of open now in terms of their new clinical space, 4 additional clinical rooms. Blythe, we had about 550 or so square meters of vacant space. It'd been sitting empty probably since the previous sort of GP practice in there had sort of closed up and merged off. We came to an agreement with the Foundation Trust that they would take on that space by vacating an old building that they had in Morpeth that again was a property services building. So we were able to offload our liability for that vacant space, making us quite a considerable annual saving of about 138,000 a year. But it also unlocked a sale of that building in Morpeth. So NHS Property Services sold that building on and then pledged to reinvest that money back into the estate here in Northumberland. And we're seeing the benefits of that in terms of what we've seen at Gables and some other sort of sites, which we'll pick up a little bit later on. And also the Riversdale surgery sort of consolidation to Oaklands. Again, we created some additional, we were able to, working with Property Services, create some additional clinical rooms for them and some additional improved back office facilities, once they'd made that move. And there's also some potential ambition that we could do more on that site because we do have vacant space on that first floor as well. And that's something we'll look at to support the primary care networks a little bit later on. Relocations, I think you're probably very familiar because these have come through the PCCC in terms of the approvals. Obviously, the new Felton surgery, which we're hoping is back on track now, and we're hoping to see that come through in the next sort of 12 to 18 months. And more recently, Elsdon, which just recently sort of got sort of approval in principle from the board. But that's going to provide some significantly improved facilities for staff and patients. There's also the lease regularisation programme, which was something that I've been working on since before I started here at the CCG. That's really come a long way. It's really quite a mammoth piece of work, but we're on track now to have 23 leases completed. I've got June on there. We may slip a little bit into July, but that's just, in terms of we had some slight delays during COVID and obviously the transition into ICS and management of money, etc. But that's a huge piece of work. And alongside getting these leases regularised, it's allowed NHS Property Services to unlock some additional investment in their estate. So, just picking up a few of the things there, there's about nearly £800,000 of investment there across those 5 sites, and we've got additional investment coming through as well. So it's been a really joint kind of working programme with Property Services, with the practices, with the LMC, the support of the LMC to get that through. Which has been massive, and we've been able to negotiate that debt figure down quite significantly with Property Services, again allowing reinvestment back into the estate. So it's a huge piece of work, and I'll be over the moon when that one's finished, sort of towards the end of July. We were also able to sort of capitalise on sort of the digitisation of records, sort of. I know not all the digitisation has worked, but we were able to sort of secure some money from that programme, working with Nex and support with Anth Brown, who's been fantastic helping us out with this. We were able to target some money specifically to take records out of a number of practices, about sort of 16 practices, I think, in total, that then allowed us to repurpose that space where the records were stored. And it was primarily focused on creating additional clinical space. So by removing the records, putting them into storage until they can be digitised, we could bring in some investment from Property Services, but also from the CCG. And on the back of that, we created 33 additional consulting rooms and 14 e-consulting areas. And we've still got more to come because that's just 16 practices. So we're looking to really continue that sort of progress as we get the digitisation up and running towards the end of this month and next month. So that's been massive. I mean, 16 sites, 33 additional clinical rooms. That's a lot of clinical hours that we've been able to add into the system, and it's taken a lot of pressure off a lot of practices. So that's a huge piece of work. It's not totally finished yet. Some of the building work is still ongoing, but we expect that will all be completed by maybe towards the end of July, and all of those clinical rooms will be online. So that's a huge piece of work. As well, working with Property Services and some other sites, we've been looking at some extensions where we've been able to secure some investment. So Bedlingtonshire, again, they were our sort of pilot site for the removal of records. We've got 2 additional clinical rooms there, plus 2 e-consulting rooms, and that was our most sort of, that was the top of our priority list when we first started Bedlingtonshire. So that's really made a significant difference to them, and there's still a bit more work to do. Additional rooms at Alnwick, Belford, and also branch end surgery up in Stocksfield. Again, we're looking to create some additional clinical space for them. And then we've got approval for the next sort of phase. I've got a meeting with some of our private landlords. There's a number of sites across the patch that are under PHP, who are private landlord. Those leases are coming to the end of their sort of life. So there's an opportunity there that if the practices would like to renew their tenancy, that there's an opportunity to secure some significant investment in those sites. So we're probably looking at sort of up to 150,000 per site, so thereabouts. So there's a lot of work to be done at Ponteland, and also the likes of Burnbrae, Seaton Park, Woodrington. So we're looking at getting some landlord investment in there and making some significant improvements on the back of that. So again, no liability to us, no cost to us. So we're trying to make some savings there. And we also, on the back of COVID, it's sort of worth mentioning, because obviously COVID's been involved in all of this process. So we've done very well to get as far as we have with COVID being in place. But we were able to get about 420,000 worth of investment to support infection prevention controls. So that allowed us to change flooring in clinical rooms from carpets to good clinical areas, to sort of make those kind of waiting areas safer, put some things in place for social distancing, etc. So that was really quite significant, and all of that work was completed last year. And then we're also looking at ongoing work that we have with the primary care networks as well, in planning their sort of strategies, which I'll come on to later. In terms of next steps, we've still got a lot to do. We've still got practices that still need some investment, and are still sort of struggling with capacity, particularly just with their GMS contracts, as well as additional roles and PCN work. So Cramlington, Blythe, Hexham on that list. The relocations that we're looking at that are coming through again, which the board are quite aware of, in terms of Brockwell. Dinnington, we're probably going to see an application sort of in June, and then we know we've got these on for future options in terms of Wellclose and Lintonville, possibly moving on to hospital sites, which we'll probably see business cases coming through relatively soon. We've been working with the PCNs. We brought in Turner Townsend to help all of the PCNs run some workshops with them to help them develop their estate strategy, focusing very much on their ambition and what their clinical need is, not focusing entirely on specific buildings. It was more about working out what they needed to do, what they needed to deliver, where the gaps, where the issues were, where the capacity problems were, about how they want to deliver their services, how they want to change and improve, share their kind of workforce around each PCN and make things work. So we're working up those PCN strategies, and again, they're nearly complete now. They're in a very good position. So we'll be able to integrate that in with our estate strategy and see where we can target investment for the future, and get those spaces, get the capacity in the system to allow them to deliver their PCN work and the additional roles. And and then sort of lastly, because our initial sort of criteria, our initial sort of priority list was based on quite a small set of information that we had. What I'd like to do as we move into the ICS, because I appreciate money will be a little bit more difficult to come by. We're going to have to be competing a lot more with all of the rest of the north of England, the rest of the ICS. So I'm really keen to sort of get a very robust data set to sort of just evidence and showcase really where we need our investment, and back that up with the staffing data, the clinical data, exactly where the service demand is. Looking to get sort of 3-facet surveys done across the estate, so we can evidence where there's actual real need for investment because the buildings aren't fit for purpose. So we're going to pull this together in quite a large, significant, sort of robust plan that we can take into the ICS, that will be a real clear evidence of where that investment needs to be, what that needs to look like, and allow us to plan a little bit further into the future as well, because we'll be able to identify what buildings just aren't going to work for us long term, and where we do need to think about, does that need to be replaced or significantly invested in. So that's an ongoing piece of work that we're doing, again supported by Turner & Townsend, by the BI team, again by the PCN estate strategies, that we should have ready sort of July, August kind of time to take forward. And again, we'll back that up with our our approved estate principles and approval criteria that we passed through the board just a few months ago. So yeah, so that's a bit of a whirlwind. I'll take any questions if anyone has anything.
Thanks very much indeed, Jamie. That was a really interesting and very cheering presentation, I think, and it particularly interests me because when I first joined the CCG, and I can't remember if it's about 7 or 8 years ago, I'm not sure if we actually even had a formal estate strategy in those days. And so I've watched this develop, and of course it's really paid dividends, hasn't it? Because once you've got the strategy, then you know what you want to do. You can prove where it needs to be done. You can then bid for funds because you've got good evidence behind you to show where the priorities lie, where the needs are, how you can best spend the money. And we're now really seeing some extremely positive outcomes from just that initial development of the strategy and the sophistication that's gone on as you've refined it and you've come in, Jamie, and you've driven it forward. So I think it's a really good piece of work. Thank you very much to you and to all your team, and keep up the good work in the future. Thank you. I've got Siobhan and Pamela to come in. Siobhan first, thanks.
Thank you. Yeah, we definitely employed Jamie at the right time, didn't we? I don't think we realised how utterly essential it would be. I think one of my reflections on how much clinical space has been created in all of this is how much of it's come from COVID. Like quite a lot of this opportunity and thinking differently has really come from one of the most awful catastrophes that have befallen us, which is really interesting, but it has kind of accelerated quite a lot of thinking about space. And I'm sure, Jamie, over time, quite a lot of our estate strategies will become much more integrated in terms of estate for the whole of health and care, and not just the primary care estate.
Thanks, Siobhan. Pamela?
Thanks, Janet. Yes, I did just want to mark, as you say, since Jamie joined the team and focused specifically on estates and premises, we have moved leaps and bounds, and I think those successes and outcomes really show that. But I think the other thing I wanted to stress was the strategy Robin and I pulled together probably, I think it's 7 years ago now. I can't remember when we wrote that first primary care strategy. The estates and premises is really pivotal, and I think it's aligning that with workforce, digital options, models of care and delivery. And that thread that Jamie's doing in that last piece of work that he explained, estates and premises doesn't stand in isolation. And I think bringing digital, workforce and all the other elements of the strategy much closer together in the work we're doing across the CCG and as a team in primary care, I think that realises the benefits, and I think you can see the benefits a lot better, especially with PCNRs, employment, the growth, and just the quality. So it's a big well done from me as well for Jamie, because he has focused and dedicated a lot of effort and time into doing the whole picture, not just estates and premises.
Thanks, Pamela. And that also demonstrates how much this needs to be kept close to a place. Although funding is going to be further up the line, it just shows how important place and work streams and ways of working are to get estates right. Jane, you wanted to come in, thanks.
Yes, I just wanted to record from the local medical committee. Thanks to Jamie. Like Jamie, I think this is one of the longest running. The leases is one of the longest running projects I've ever worked on. I think it's tipping 6 or 7 years now. Anyway, but thanks. And also, I think the value of having somebody with his expertise sort of linked into primary care, so that the issues are understood in detail. And responded to appropriately, and so thanks from the practices, because I think that's certainly the lease issue, although it is not taking centre stage here. It's been a big problem for over half our practices over the last few years. So many thanks.
Thanks very much, Jane. Well, I think there are lots of bouquets being thrown today, Jamie. Thank you. Really good piece of work, and all the best with maintaining it. As you say, it's going to be more challenging as we go forward into the new future, but I think we'll be very well placed, won't we, to evidence any bidding, etc., that we need to do. So that's excellent. Thank you so much. And
no, it's fine. It's fine. It is a very much a team. I can't do any of what I do without finance, without the primary care team, without the BI team. It is a massive team effort. It's you know, it's certainly nothing I've done in isolation. Property services have been a massive sort of help as well, and the practices themselves, you know, being open to sort of change, open to looking at things in a different way. So it's a huge, you know, collaboration and a huge sort of team effort to get across the line.
Yes, all teams are always the ones who achieve everything, but it's the leader that holds the team together as well. So thank everybody from us as well. Thank you, Jamie. And that, I hope, is going to end us on a high note, because the next item is any other business, and I don't have notice of any. So unless anybody's got anything burning they can convince me needs to be raised now. No. In that case, that takes us on to item 6, which is the date and time of the next meeting. You'll probably remember that normally it would have been June, but we've got a lot of applications of one sort and another coming forward. And you know, of course, the papers behind these are always quite significant. And realistically, we weren't going to be able to fit them all into a June meeting. And we don't want to postpone them because obviously for practices, they don't want things like that postponed. They want to get a move on. They need to know where they're going. And also after the end of June, we don't know quite where we're going to be. Possibly we won't be here anymore. So again, another reason not to postpone. So I hope everybody could check their diaries and see if they can make an additional primary care commission committee meeting on Wednesday, the 18th of May. I leave that one with you. Perhaps if you would be kind enough, you've probably already had a circular from Barbara about it. It would be really handy if you could let Barbara know if that is or isn't convenient as soon as you could, because I know people's diaries are tricky, and the sooner we can book the date, the better. Because I think it's really important. We are not going to be able to get everything done in June. So one way or another, we need to try and fit something in, ideally on the 18th of May. So I leave that one with everybody, and then almost certainly we will be continuing, of course, with then the meeting on the 8th of June as well. So in that case, thank you everybody for your attendance, and we'll now stop the recording of the public meeting. So I'll just give Barbara a minute while she sorts that out. Thank you.